That was great. Thank you so much to all the panelists. Okay, I see a couple cards up already. So let me start with John Hicks.
Thanks to the whole panel, and talk about a broad perspective, that we're getting. It's fantastic. Dr. Schwartz, you mentioned a couple of reports in which you'd made recommendations on improving some of the systems, and I don't necessarily see those in our briefing book. If there are recommendations or reports that we should be considering, I may already have them and just haven't seen them in the Dropbox, so we would love to have those available to us. To Umair and Skip, I think a point that you guys would agree with from a reinforcement standpoint. One, getting hospital mortality data is not a great source because for trauma, once you get to the hospital, you seldom die. And two, ER docs like myself are notoriously bad about coding mechanism. Is that fair?
Yes.
Okay. So
yeah, but I would say one thing, that what I'm seeing is different than your experience on particularly the younger physicians. You can't give them a paper and pencil and ask them to chart. They freak out. They want it on a computer, and so right. Well, yeah. So I that's something that I've kind of have seen. I knew that day would come when we introduced electronic medical records, and that people would get so used to it, they won't. Our first contingency plans did have paper backups, and I heard this multiple times over the last couple of days. That's gone away. We got to have, even if we don't have connectivity, we've got backup computers that can run on whatever emergency power that we have that may not be connected, so they continue the electronic charting even in a downtime environment. So just a FYI.
No, that's a great point, Skip. And I think tablet-based and other-based, capture of the medical record data that can be backloaded into the system once it comes back up is going to be the wave of the future. As I heard Kevin mention scribes, and I totally agree. That was one of the interesting points that came out of our Las Vegas visit, was the scribes played actually a critical role, and yet weren't included in anybody's disaster call-in plan. But it was them that got the surgical notes and a lot of the stuff into the chart, so there was something in there for the teams upstairs, once they got to the floors to work off of, and I think they had 18 scribes in there that night. And I think just to reinforce, Kevin's point about that on the ground data, when we went out there as a team within, a couple of months after the mass shooting, we were able to focus on the operational details that nobody else was asking about and get stuff that was useful to other facilities from a future response standpoint that wasn't going to be captured in any other after-action reports. And I think the same thing applies here. There's details about the underpasses that we heard about, or being in ditches or things like that, that if we don't have some on-the-ground people doing interviews and really looking into the details, we're going to miss that, and we're going to miss opportunities to prevent morbidity and mortality in future events. So that's a lead into my question to Umair. If, based on the way Harris County reports out direct disaster mortality and the way Florida reports out indirect, you would think that hurricanes in Florida were 3 times more lethal than they are in Harris County, which, credit to Harris County. But I think there's an opportunity with those indirect deaths to identify, lack of access to care and breaks in our continuum of care and untreated injury and medical conditions, where there's probably our best opportunities, honestly, for future improvement. So where does that nexus, where do you see that nexus lie? Where do we get that info, from, if we can't get it from the ME?
Thanks, John. So I think you bring up a really challenging point for us in the community. So it is true, our medical examiner, our partners at the Institute of Forensic Sciences, they look at direct mortality data. And so as I shared with the committee previously, that the 36 deaths from Hurricane Harvey in our community, 34 of them were drowning, including 6 that unfortunately were a family of those 34. One was an electrocution, and one, the last one, which moved into a little bit of infectious disease, was a blunt trauma of somebody falling in the home in a essentially polluted water, if you will, and wound up also having necrotizing fasciitis. So I think there were, that was the 36th death, if you will, to account for it. I think the challenge is that really it's about how do you code and how do you work with your partner at the medical examiner if you have that medical examiner confidence, trust, as well as partnership, not just in emergencies, but on an ongoing basis. And as we all know, that you cannot build those relationships in the middle of the emergency. You have to build those relationships in advance of and certainly during and post the emergency. And so the challenge that we have is with our medical examiner. They're fantastic, but then you go 5 or 6 counties over and you're in a rural county, and again, we may have a justice of the peace that's actually going about doing that work. And nothing against our system that's there, but to say that the training just isn't there. And so I think there are 2 things. One is it's not just Harris County and the fact that we have the infrastructure and we have obviously sophisticated health department, public health system as well. We also have to be thinking about the inequity that occurs when you're 5 counties over and communities over and you don't have that in a rural, and how does that then work back with the state infrastructure that provides support, and does that go to Dr. Yeski's point about then the federal support? Is it more accentuated in those communities when you have a community that is maybe more has more infrastructure and is able to respond? So I think there is that inequity and disparity that we have to really be thinking about. But then to your specific question about what else can we bring to the table, and I think this is really the rubber meets the road, because we do have a number of changes that are occurring in our system, and Skip mentioned those, from these data systems that are both evolving and they're certainly transforming. But we also have, as you all saw in Las Vegas, you have Uber and other demand activities that are allowing for electronic systems that are somehow collecting data which aren't always related to morbidity, mortality, but they're related to transport, right, or response. And at the same time, we recognize that a lot of folks, not everyone, but certainly you've got a propensity for people to now start to have, Apple Watches or platforms like, what am I thinking of? Apple Fitbits and those systems, as well as we certainly have a lot of access to email and electronic systems that people have. So when I look back to Katrina in 2005, for example, and I think about the sea of people that had put up signs to say, "I've lost my child," and they were paper signs. And this is 2005, which is only, 14 years ago. And now you look at Hurricane Harvey, those same people were not putting up paper signs. They were actually now using Facebook and Twitter and Instagram to locate even within shelter where their potential people were that were lost. Nextdoor app, they were looking at obviously text messaging and all sorts of systems, but I think the challenge that we have is that there is a sea of information that's out there when it comes to all these electronic data points. Now, how do you navigate those data points, and how do you get those data points in a more meaningful way, streamlined way, that just doesn't become so much data that it really becomes overwhelming and not used appropriately. So I think crowdsourcing and looking at individual technologies that are part of it are part of the solution. But then I do think that Dr. Yeski's point about data systems not sharing across the spectrum is absolutely critical. We found that as the health department, we didn't have a dog in the hunt when it came to which hospital, which data system was reporting an injury or an illness. It didn't matter to us. It wasn't a ding against the hospital to say that this hospital had maybe increased morbidity or mortality related to the number of evacuees that were coming into their emergency department. That's not what we were concerned about. I mean, obviously in the long run, you're concerned about quality of care, but we're really concerned about enumerating. We're concerned about data patterns and disease patterns and trying to design interventions. But that hospital system is very reluctant reluctant to share that data because it now competes with another hospital right across the street. And so now they're having this real challenge of saying, we're not going to share it, certainly not with each other, but we certainly don't want to also, or we want to be careful how we share it up the chain to the health department or to emergency management, because the concern being that it may be proprietary information that's going to start to reveal operational deficiencies and or quality of care deficiencies and or something else that is going to now make that hospital in a competitive environment feel that in some sense it's lost its ground against its competitive edge with the neighboring system. That's got to change. And I'll stop there. I think there are a lot of, with technologies, but also systems individually as well as collectively, we have to be thinking about how do we bring those systems together and really start to speak the language that really allows us to share across the spectrum.
Thank you also to the panel for your comments today. Just a couple quick observations, then my actual question. We've talked a lot about paper backups to the electronic medical record. I just want to mention, when Katrina hit New Orleans, the VA had evacuated most people, but there were still a number of people left behind, and they used paper records. They knew how to use them then. It was a while ago. But it was no small issue who and how the data was ever actually going to get back into the electronic record when it actually came back up. So, there's a lot of operational issues that have to be dealt with. So the scribes is an interesting point. The other thing, I'll just back up, skip a little bit, in terms of the mortality data and not to go to hospitals. So the VA runs one of the national cemeteries, and we don't have good mortality data, at least not for many, many months after either. So we get it from the vital records and other things too, eventually, to enter it into it. My question, I guess, is for Dr. Yaski, just kind of following up on, the suggestion earlier about reportable. You mentioned the Oklahoma bombing was reportable. By whom, to whom, for how long did we track, et cetera?
Great question. I don't know the absolute answer to that. The reporting was to the state health department, like they would report other reportable diseases, and it was for any provider, licensed provider. I think it was any licensed provider who saw patients for the acute care of that. Now, I don't know if it included long-term mental health. Someone comes in 6 months after the bombing with issues there, but I don't know the answer to that, but that's the way I understood it was set up.
Okay, I think Craig?
Happy anniversary, belatedly, by the way. I have a couple of questions, perhaps, that would be, you may not have picked up on this, Skip, but, this discussion that John and Kevin had with the folks out there in Vegas. The question is, how does morbidity and mortality data from those kinds of events get transmitted to you systematically? And how do you use them systematically then to inform your hospital staffs about what that event taught us in terms of what they should anticipate should they be encountering such an event? I mean, we had another one in another HCA hospital just 3 weeks ago in Del Sol in El Paso. We're getting pretty damn experienced in the HCA system about the idea of using, dealing with mass shootings and those kind of events. But how does that data get to you as a person who has some insight around your hospital system, and how would you use that information?
Right, it's a great question. In the moment, in the moment of the event, and it just depends on the circumstances. So Las Vegas, we don't have a presence. But we had people there, and so we had another system to get them connected to make sure they were okay and get them back. So that's a different, because we could have had casualties, obviously, because there was a nursing convention ongoing, so I had a number of nurses in town. Some of them were at the concert. So that's one level. it didn't impact us where we had to do transfer because it would have been, it's a come as you are situation. So if they would have been medevaced in or come in via ambulance, whatever we got, that's what we go with, and we start all over at the front of the ER. Unless they're a member, then we can look at the longitudinal data that we would have for their case. So it's tragically, it's more of a lessons learned, and I know we picked up early on because we heard from the facilities impacted, the nature of the wounds was something that because of the elevated position and the impact it had on the surgical teams and people evaluating, that was new information. So through not just grand rounds, but really intensive training, so people that are practicing medicine can understand this is the new wound and disease that you're going to have to deal with. So it's sad to say that it was. That's been my experience of where we connect with those kinds of events.
Yeah,
Can I just?
My point is that it's a surge issue, and it could happen to your facility in San Francisco or LA or whatever. And so the question is, how can you use that? And
oh, well, then okay, I didn't understand the question. So that's through practice and through real live events. And one of the issues, as I was thinking of this panel, we had fortunately it wasn't, there weren't mortality issues associated with it, but definitely morbidity, comorbidity, and throughput issues. In Richmond, California, there's a refinery. There was a refinery fire that really impacted the city. We have a hospital really close to that refinery, and boy, the surge was overwhelming. That was a lesson that we learned on our electronic medical record, because on a day-to-day basis, if you present at the ER and we need to move you through the workflow, unless you are a member, there's a hard stop in the system. You can't make any referrals for imaging, no referrals for lab. And so that obviously is a limiting factor that we had to overcome in a hurry. So we had to work with, and our system is Epic-based, we had to work with Epic to set up what we call a disaster code or disaster mode. So if we see those surge situations, we can turn the switch. That'll allow for, whether you're a member or not, because remember, we're a community asset. If there's an event like that, there's no differentiation whether you're a member or a non-member, whether you can pay, not pay. We're going to get you seen and get you treated and get you released. So that's something that we learned on the fly that we had to account for and be able to accommodate that. So and through practicing, because you don't know the interdependencies, you don't know where the points of failure are until you have to surge. And fortunately, we don't have, it doesn't happen enough so that we have that muscle memory and that instinctive pattern that you want to rely on. So we tend to drill it. And do that, and I don't think you can over drill that. You just got to keep doing it to build the confidence that you need to handle those situations. So I hope that got to the question.
I just want to add a quick comment that, to Dr. Shaw's point about competition, you could get all the sickest patients because you're the best trauma center in the county, and that's where they take the sickest patients, or you could be the closest hospital to the event and get all the patients because that's when someone hit their watch and it said around me and there's the hospital, and they went on maps and took people there. And one is luck of the draw and one is great planning and preparedness. The end result is the same. You had the most mortality in your hospital and we didn't. And that's the challenge of how you use this data and not keeping it in the context of the overall healthcare and response system in the community that says, we took the sickest ones there, and yeah, we would expect because of the nature of the injuries, they had a higher mortality rate. But
I
the
have one
fact is
comment
they're
about
better.
this, and then I had a question for you, Kevin. The comment was that, my concern, of course, is that the hospital system is the weakest part of our capacity. And so the question is, how do we help the hospitals take advantage of that real learned knowledge using that morbidity data, et cetera, to inform it. You don't have to answer for everybody, Skip. That's not my point. The question I was going to ask you, Kevin, was Kelly made a comment this morning, and this goes to your Murrah building thing, was would ASPR be somewhat interested, thinking regionally, in providing some grant to vital events operations in 2-3 states that are closely approximated to help them create a greater standardization of approach to providing you with that information? I'm just asking the question. You don't have to answer it.
Yeah, I can use a one-word answer. I can take the rest of the 12 minutes that we have. But basically, yes. I mean, we're interested in how we can improve our state, local, tribal, territorial preparedness in a number of different areas. Now, where the funding comes from is a whole different conversation.
Mike and then Charlie.
Well, another set of terrific presentations. Thank you for all this. My question is for Dr. Shah. You mentioned in your opening remarks about building a data warehouse to manage all the data that becomes available and to use it. And I think you also then, in your response to the last question, talked about how to use it during the response itself. So I wonder if you can just tell us more about that, about the kinds of data that are available, about how you actually use it. What are the uses to which it's put?
Thanks, Mike. Good seeing you. So the data warehouse is a several-year journey, and we are not completed with it, so it's in process, if you will. And I always like to say that because we are markedly further along than we were last year, and further along than we were 3 years ago, and further along than we were 5 years ago.
And I think a lot further along than many health departments.
I would say that, and I don't want to overspeak, but I do want to say that the way we're looking at, so our core values at the department are innovation, engagement, and equity. Those are our 3 cornerstone values, and the data warehouse actually speaks to all of them. And the innovation piece is really looking at not just the data systems that we used to pretty much have on Excel spreadsheets and sometimes paper pencil type of thing over the years that were parts of our siloed department, and people weren't sharing from epi over to environmental, over to mosquito, to animal, to clinical, that there were silos within our department. So what we did is we started to break down those silos within the department. That was really the first step, and we started to share within the department what those data sets that people had, but they were using, right? The epidemiologist was using it to go and quantify and somehow enumerate what was happening in a tuberculosis activity, while at the same time we were going out and doing food inspections for restaurants, and there was no crossover of that data system, right? Or even a more markedly important example in the middle of an emergency was that when our environmental health folks were going out as sanitarians and our mosquito control folks were going out to inspect and or spray, there was no cross talk. So we decided that needed to change, and that was the beginning of the journey. That journey was several, like I said, 5-6 years ago, but as we have now more matured along the way, we started to recognize that, by the way, there are a lot of academic institutions in our community, and I think somebody had mentioned Rice University with the registry, the Hurricane Harvey registry. We're one of their partners as well, but there are a lot of academic institutions that have also data points that are locally generated data. Then we obviously have our state partner, and we have certainly state partners, and primarily Department of State Health Services, but certainly beyond that, other state systems. And then to Kevin's point around the real federally available data systems, all the way from what you would expect from a CDC or from ASPR, but also thinking about CMS data and really the ability to even get into HUD data and look at DOT and DOE and all that. There's all sorts of alphabet soup at the federal level, but what we recognize at the local level is that while these may be different data systems, different agencies, different activities, different streams, at the local level we are the EPA, we are Department of Transportation, we are HUD, we are CDC, we are ASPR, we are I mean, you go down the list. And so what the real challenge we found is that these systems at the federal level do not talk to each other. And so then when they fund back to their state and local partners into the community, for example, a school, there is no incentivization for that school to be able to share then back data to the local health department like us. And so we then have to work with the local relationship, working back up the system chain back to the federal level. And it would be a lot more effective if we could get a bi-directional where it's locally generated as what the issues are, the challenges, but also that at the federal level, those entities are recognizing the importance of that integrated cross-disciplinary data systems and sets that can then ensure that those entities at the local level are sharing that across the board as well. That's low-hanging fruit. It's very difficult to do, by the way, but low-hanging fruit that I have not seen in my 15, 20 years in public health that's really ever been fully addressed. Partially addressed, but not fully addressed. We even had just recently HUD that came down, just a community event on a lead-related community event just a Saturday ago, and we were struck by how HUD was looking at this issue and how CDC was looking at this issue. And really, they have integrated across the system, but maybe not as robustly as at the local level we see, because at the department, we do both. And so I think that's been the real challenge, and that's why I say it's a journey, that it's several years in the making. We started off with what locally we had within the department, and we've expanded it now. We've been invited to France in November to actually present at the European Public Health Association on this data system, this data warehouse, and the innovation road that we have. But at the end of the day, unless we get data partners to be able to feed into and be able to have access to and have all those shared agreements that allow us to get that information, really it continues to be limited in scope from what our vision is for the future. So that's, Mike, I think in a nutshell where our journey is, and certainly we recognize that other health departments are also going through their similar journeys. From a swim lane standpoint, there are a lot of health departments that I would say are really at the advanced swimmer stage, and they are swimming, they're bringing in syndromic surveillance and doing all sorts of things. There are other health departments that are somewhere midstream, and they're swimming in there. There are others that are sort of in the water, they're flailing. And then there are other health departments that are actually, they recognize there's a pool there, but they don't even know how to get their shorts on and their shirt and to get into the pool. And so we're really understanding that you have to really recognize all those swim lanes and figure out how do you actually get to all of those health departments. Remember, as the president of NACHO, I represented 3,000 local health departments, but the vast majority were the smaller jurisdictions, not the Harris counties of the world. And I think that's the big challenge that we have, is really how do we speak across the system to the more integrated, more sophisticated, more robust, but also what's happening in West Texas or what's happening in, the frontier part of the state of Washington, et cetera.
So, I mean, recognizing that there's a lot of variability, I think it'd be really helpful if you would share with us the presentation that you do in the European Public Health Association to get some concrete. I mean, what you say sounds terrific, but I'd love to be able to see the concrete version of it. Maybe. Yeah, we've been tasked. We've had a change in governance at our county level in January, and we've been tasked to look at a comprehensive health and healthcare study for Houston Harris County that's actually to be presented in November, and that has actually been the most recent example where it's not just qualitative, it's not just community voice, it's not just talking to partners, but to where we actually bring in the quantified information that our data system as part of the data warehouse is bringing together. So I think we'll have a lot more by November, but certainly we'd be happy to share that with the committee if it's helpful.
Charlie?
I'm going to follow up with what John was asking you, Steve, but I'm not going to be as nice. I got this feeling that you've got everything under control, and I'm really glad. I'm glad things are going so well. I saw this nice little picture here. I saw the map that you all put out, and only 4 states don't have electronic systems. You were talking about you can code 77% of the deaths automatically. Sounds great. some of the things I'd like you to maybe come back to us on, you don't have to respond to it here, is number one, of those 77, of the 23% that aren't coded, almost all of them are medical examiner events, okay, and most events that have immediate public health importance. What do you need in order to improve that response so that those critical events can be coded as quickly as those events that we probably could look at next month? Number two, yes, there are 4 states that don't have EDRs. And you've gotten opioid funds to help you get there. I'm more concerned about those states whose EDR systems are hanging on by their fingernails. Are they really going to be able to be updated, and what's it going to take in order to really make changes? And are all those EDR systems really statewide and really being utilized appropriately? Another issue is we've talked about silos and data sharing here and yesterday. What are the possibilities of having, instead of medical examiners having to go to their system and the EDR system, why can't we have some sort of data sharing between them first of all, to improve data and also to make it less onerous on them? If we need additional information on cause of death, why isn't it that there isn't some relationship between electronic health records and the EDRs? And as Skip was pointing out, after the death is reported, why can't that information be provided back to the original provider or physician into their electronic health record so that they can do monitoring of their own? Why is it that, if I remember right, Robert Wood Johnson got involved with NCHS on doing geocoding of events, of mortality events, so that you could do life expectancies at smaller geographic areas. Why aren't we geocoding everything for all our mortality records? I mean, and why aren't we doing that real time? What would need to be done to make that happen? And why can't we provide that type of information back on a real-time basis before disasters happen? In other words, what is the expectation of mortality in normal conditions in X area? And then if there was a 5% increase, what would that mean? And give levels of expectation that are based on solid information. And I can go on, but those are the types of things that I'd like for you to come back to us on, because if not, then what we're going to do is look at other areas that need help. So just thank you.
We'll get back to you in a few minutes. Okay. So sorry we're out of time. Very good points.
Okay. Any other questions? Oh, sorry. Yes, Maureen.
So, Mary, you didn't, how would I say that, disappoint. I knew that you were going to bring us information that was innovation, true to what your department stands for. What would be your dream data once this data warehouse system is done? What would be your dream data that you would want at your fingertips before and immediate after a disaster?
So let me start by the disclaimer that I'm not allowed to dream. I think it's really a shared dream that all of us have, which is that we have access to an incredibly robust set of data points and measures and metrics that really allow us to the comment that was a set of comments that were just made, that really allow us to have a baseline of what's happening in our community. I think at the end of the day, we really need to know on an every single day, night basis what is happening in our community. And whether it's a small community, it's a large community, whether it's very complex, complicated, but we want to just have robust information at our fingertips that you can simply hit a button. And I remember Dr. Khan showed this to me at the CDC, was really always impressed by where this map goes up and boom, it's got everything. And it's not just that it's lineless, but it's actually data visualization, that it's a map that shows you what's happening. So you can say where hotspots are, where you can really understand better where things are happening in your large community. So when we're spread over 1,800 square miles, it's one thing to say it's county-wide data. It doesn't help me. Does not help me. It only helps me if I know where specifically in the county there is an increase in A1C for diabetes, or there's an increase in HIV transmission rate. It only helps me if I know where that's happening. We don't have the where. And we don't always have the what, but we certainly don't have the where. So that's the pre. In the middle of the emergency, it's chaos. And when we are an impacted community, and I remember this very this humble point of humility, and really, Maureen, this is really back to you from New Orleans, is I remember when a fellow agency made a comment when we had Katrina evacuees who came to Houston and made some comment about how I can't believe they didn't have access to something. And I can't remember what the issue was, but I remember saying, with all due respect, what do you think when there's water in your home, or there's water in your office, or you're worried about your children, or you're worried about insurance and what's going to happen? You've been displaced. So have some humility when it comes to being an impacted community. And then guess what? In Hurricane Ike and Hurricane Harvey, we were impacted communities twice, and in those events, and it was chaotic. It was chaotic because we were now worried about our own mental health. We were worried about our own physical health. We were worried about displacement. So now in the middle of all this, you have staff members who've been displaced, who now are passionate. They're working 20 hours a day, and yet they're worried about their families. And those systems should be able to help those responders be able to look at data systems. But even in the middle of the emergency, you don't have that access because we haven't built the system up front. And so in the middle of that, then it's even harder. And then post, we go to the next disaster, right? So Harvey was followed by, as you all know, a series of hurricanes, including Florida and Puerto Rico. And so the attention very quickly shifts to the next emergency across the country. And so what happens, or even locally, our Hurricane Harvey efforts were then compounded by, more recent other events such as measles identification, or, the chemical fires or other activities that are happening. And so we're now in the middle of responding, and now we're recovering from that response, and you have the next emergency upon you. And so I think one of the challenges that we have, and I think Dr. Yeski brought this up very, very nicely, is really how do we catalog back and look at those systems and be able to really, at the end of the day, learn from them, but also have access to them pre, during, post, a robust system that allows you to understand up and down trends, and really at the end of the day that gives you horizontal, vertical, and diagonal information that we do not have access to currently because people are, for whatever reason, have too many barriers to actually share across the system. And that's what I would really, that's the dream, is to be able to walk into my office, or actually on my tablet or my phone, to be able to have it where I can very quickly say, this is happening in my community, and I should be able to very quickly be able to figure out what's happening, layer all the information around it, and be able to design the interventions very quickly on for whatever the issue is. Unfortunately, that's not there. And I think that's the challenge for all of us and all of you as part of the committee.
Can I just dovetail on that for just 1 second? I think you brought up a really key point that I think, for me is also super important. That is the granularity of the data. That the data allows you to take an action that makes a difference. It doesn't help you to know that your average EMS response time across the city of Houston is 15 minutes, when in certain areas of inundation it's over 100 minutes, and in certain areas it's under 3. If you don't have the, if I can see that my daughter is driving 30 miles an hour in town, that's great, but it doesn't tell me that she's doing that on sidewalks, through parking lots, and around corners. If I don't have the right info and the context, then I can't take the actions to either help that population or, intervene with preventionary activities.
Yeah, and I just wanted to say that, this is why, John, that we say that emergencies really happen in local communities. That we are not just we do get a lot of offers for help in the middle of an emergency, and I apologize again, Skip, publicly, because I know you reached out to me in the middle of Hurricane Harvey and I still haven't responded. It's been 2 years. So just to say, I apologize. You're backed up. Is that in the middle of the emergency, we are very much responding. And so we get academic, this is not meant for Skip, but we get academic partners who come in and they sweep in and they want to learn and there are times, and we've had this conversation, where we then get asked to be pulled out to other parts of the country while we're still in the recovery. We're still responding and recovering, and we're asked to come to the National Academies in Washington, D.C. to present when we're still recovering and responding. And so there is this real challenge that we are not just sitting there, and I'm not saying that others are, but we're not just sitting there saying, how do we study this? It is not about study. It's actually about protecting our community. And it happens in local communities, and we have to recognize that those responders in local communities are also a part of the response, but they're also part of the people who are in the middle of the emergency. We've got to find ways to really make it so that we can, for those communities and for those people that are responding, make it easier for them to do their job and make sure that it's being done in a robust way, appropriate way, and well-resourced way, so that we're not catching up after the fact, but we're building the capacity up front. And I think that is absolutely critical to how we look at this.
Let's take one last comment from Ollie, and then we're past time.
Great discussion about data and uses of data and gaps in data. And again, Dr. Shah, excellent point about what data gaps are, but then I often hear from states that they get too much data from various federal agencies in the middle of response and they don't know what to do with it. So we really have to also tackle issues around data visualization, analytics, and advanced predictive tools. So you can, if somebody sends you the Empower data, I've had people tell me, I was so glad we got it, I didn't look at it until after the response, because I was in the middle of the response. And I'm sorry, Dr. Yeski's thinking, but how we could have helped you with this if you had asked us. My question goes to Dr. Schwartz. So Dr. Schwartz, I think you should ask the former director of NCHS what sort of shambles of a system he left you with. But besides...
I'm sorry, what name exactly?
but besides that, I want to ask you a question. I think you've probably heard me frame it over the last 2 days, but I'd like to get your input on this. It's really about how do you move from the traditional way we think about vital statistics, and not just deaths. I'm going to say births if we think about Zika and other things, and around disasters, what happens with births, to a surveillance mindset, right? So how do you move to a mindset? You have invaluable data. You really do. It's increasingly real time, which boggles my mind, to be honest with you, as a public health practitioner. How do you make that available at your own agency level? So, how are you working with the EOC and the NCEH when there's an emergency to say, here's the vital statistics data, how can this help you? But also how to help the states and their local registrars sort of do the same thing. So some of your thoughts on that about a surveillance mindset to vital statistics data. So it's not just that one number, but it's the daily counts. What do those counts mean?
How much time do I have? So that's a big question, and it's a great question. The reality is that we are moving towards that. We are moving faster at an incredible speed because the states are moving faster also. So that's one of the things I would have liked to have said at the beginning of yesterday about where the data actually come from, because many of you may, or some of you may not know that all of the data, vital statistics data in the U.S., comes from states. Does everyone know that? And do you know why? It turns out it's the 10th Amendment. And it's because in the 10th Amendment, the powers that are not delegated to the U.S. by the Constitution or prohibited by it to the states are reserved for the states. So in every case, we are beholden to the states, and from time to time, states excel and some fail. What we need is a system that actually elevates all of the states. We really need that. And the challenge is, and why we have 4 states that seemingly should be excelling, like states that rhyme with North Carolina, for example, or Rhode Island or Connecticut. I'm not going to name names. So those challenges are because they are local challenges, and what we need is a system that is robust enough to maintain all of these systems. We have fabulous staff in NCHS. We are still under-resourced. What we need is how do we maintain a very high level of quality, and it all comes from the states. So when we're talking about it, we are receiving almost 8 million records a year, every year. And every one of those, when we're talking about this, all of those death records that we've been talking about over the last 2 days, those are the records coming in through our data acquisition and classification system. And every day we are improving. How do we maintain that? It is, how do we bring every state up? That's really critical. And it's not just about funding, it's about how do we manage a system where most of the funding for state, and this is also, you may not know, another secret, is that all of the state data come to us contractually. So there's no law that says it, and it's one of the reasons why we have state data that differ across states, or may because there are state laws. And so whether it's the medical examiner system, coroner systems, how do we interoperate better? That's where we have to be, so that interoperability, and that is what we are working towards, so that we can get the data in faster and more reliably and more accurately. So it's a great question. It is a challenge, but we're really up to it. And through the opioid funding, we have been able, and PCOR funding, we have been able to move much faster. And nobody thought that there could be that the vital statistics system, the National Vital Statistics System, could ever be thought of as being a surveillance system, and it is becoming that. So we're in a good place, and we have to get better. Thank you.
Okay, I think that's a great note to end on. Thank you very much to all our panelists. This was fantastic. And